This topic will be on childhood vitiligo, when should we treat, and maybe the difference of diagnosis of childhood vitiligo. So to begin, the roadmap will be the diagnosis, the differential diagnosis, the global therapeutic evaluation, the treatments that we can propose to our patient, and what in the future is waiting. I think that much has been said with regard to the future and the conclusion. So childhood vitiligo diagnosis. So childhood vitiligo, it is almost 2/3 of vitiligo that have an onset before the age of 20. So it's not so rare. More often associated with halo nevi when you look at a patient who begin in the childhood their vitiligo. Positive family history of vitiligo has been associated with this type of vitiligo. Gardner phenomenon is common, and we have less pure acrofacial vitiligo in this type of vitiligo. Usually it is more generalized vitiligo than acrofacial vitiligo. When you see a patient, a child with vitiligo, the first thing to distinguish is it non-segmental vitiligo? Is it segmental vitiligo? Because these two diseases do not have the same outcomes and do not have the same implications in terms of follow-up. Segmental vitiligo usually begins in childhood. The disease onset is really rapid. The disease onset is rapid. There is an early hair follicle involvement, which is not the case in non-segmental vitiligo. And what is important is that you have no association with autoimmune diseases. So if someone a child is diagnosed with segmental vitiligo, you don't need to check for autoimmune diseases because usually it's a limited disease. Face is the preferential involvement side, and sometimes it's difficult to distinguish between nervous pigmentosis in case of very early onset of the segmental vitiligo. At the opposite, non-segmental vitiligo can begin later, and it is progressive with flare-up, so it's not at all the same history. Rapid onset and stabilization in segmental vitiligo, progressive with multiple flare-up in non-segmental vitiligo. The hairs are usually involved later in the disease, not early, very late, and even you have some patients, even after years and years, the hairs remain black. You have a frequent personal and family history of autoimmune diseases in this group of patients with a frequent involvement of pressure fraction side, usually relapse after treatment. And just to make it more complicated, some patients had both diseases. They have segmental vitiligo, as you can see it in this young girl that I have seen in the department. She had typical segmental vitiligo and non-segmental vitiligo. What is the differential diagnosis? So here, it's psoriasis, and here you only have one differential diagnosis for my part in segmental vitiligo, which is nevus pigmentosus. So NSV should exclude pubertyism, and you will see that sometimes it's difficult, even if it seems so easy at first sight. Post-inflammatory depigmentation, post-infectious depigmentation, post-traumatic leukoderma, melanoma-associated leukoderma, and we have a paper that has been submitted with the Dutch group and the Belgian for melanoma-associated leukoderma. Probably it is far more difficult to distinguish from vitiligo than it seems at first sight. It's really a problem for us. Now we are using the drugs that are very effective. We have a lot of melanoma-associated leukoderma coming. Melasma, sometimes it's really difficult when you see a woman to distinguish between melasma and vitiligo, and drug-induced depigmentation. Just to show you these two patients, which were two brothers, who came to see me at the same age. They are twins. They are both with pubertyism, but whereas one of them has almost completely repigmented spontaneously without any intervention, you can see that the other was not repigmented. And if you see this patient without this white fair lock, you can say that this is pubertyism. It's difficult. You can easily confound this condition with vitiligo. This is something that you should be aware of because this is not depigmentation, this is a hamartoma, ash leaf lesion. It's in tuberous sclerosis. Sometimes they are referred by their physician, general physician, with a diagnosis of vitiligo, but you should look for other signs of tuberous sclerosis. This is typical from tuberous sclerosis. Okay, I don't think this is really something that we should look because it's really not vitiligo. It is classically said to be differentiated from vitiligo, but this is hypomelanosis of A12, it is not vitiligo. And here are the genetic diseases with Waardenburg syndrome. I took this publication that has been done in 1997. The pictures are very nice. You have this hypertelorism, the dilution of the pigment, and usually you have also the difference in the hair colors. So just to come, sometimes it can be far more difficult. But this is psoriasis, this is clear. This is a young lady that I have seen in the department who had been said to be diagnosed with vitiligo, but in reality she had huge erythema multiforme, and after the erythema multiforme, she just had this depigmentation that persists over the years. And we did biopsy, the melanocytes were present, but probably not functional. We don't know why. Sometimes it is difficult. Here you have lichen sclerosis. It is clear that it is lichen sclerosis. And sometimes lichen is associated with vitiligo, like in this young girl. This is quite easy. It's lichen sclerosis alba. And at the beginning of lichen sclerosis, it can be like this. This is hypopigmented mycosis fungoides. And this is hypopigmented mycosis fungoides. This picture comes from my colleague Nanette Silverberg. We have published this picture in Pediatrics a few months ago. This is very common that general practitioners address these patients for vitiligo. It's just Malassezia furfur infection. Sometimes it is also very difficult because it is widely diffused, but this is not vitiligo. This is progressive macular hypomelanosis, also, probably para-infectious also. And four-segmental vitiligo, as I told you, nevus depigmentosus. To make the difference, usually nevus depigmentosus appears at the first year of life after the first photo exposition in first skin time. If it appears in the first year, you have the suspicion of nevus depigmentosus. And also, the borders are not completely clear here. You have this kind of desiccated borders. And sometimes you have association between disease. This young girl, she had diabetes type 1 and vitiligo. We published a series of this study of patients with atopic dermatitis and vitiligo. And sometimes you have psoriasis alba. It's difficult to differentiate, but sometimes you have both. So also in this young boy. So once you have done your diagnosis, you should, at least for non-segmental vitiligo, do a global therapeutic evaluation, which is very important. I don't know if some of you are used to use this wood lamp, which is essential in all pigmentation diseases. I will not come back here. I discussed this morning. But it is important that you know this. You know that you have multiple phases in vitiligo, and probably you have multiple flare-up, and the treatment are not the same according to the level where you are. When you are in the silent induction phase, when you are in the clinical phase, you will not use the same drugs to repigment vitiligo, and this is important to be known. At first consultation, what we do in general, we take all this information. The European Task Force for Vitiligo has developed a special form that we use in our clinic systematically for all the patients at the first consultation, and now we are beginning to use it for the second consultation and the follow-up consultation to know how the disease is moving. So skin phototype, disease duration and extent, disease activity, all of these are important elements to guide therapeutic management, but also the presence of halonevi, the presence of trichrome lesion are important. The family history of autoimmune disease and the personal history of autoimmune diseases is important as well. In addition, you should carefully look to the psychological profile of the child, especially in adolescence. And I have seen so many adolescents with really huge psychological problems with vitiligo. I remember one coming with his mother from 400 kilometers at my clinic with a diagnosis of vitiligo, and when I first see him, I saw that it was not vitiligo, but probably something more mycosis fungoides than vitiligo. And when I talked to the parents that it was not vitiligo, they began to cry, and it was like a drama in my office. And I said, why are you so, it's mycosis fungoides in children, it can be treated, it's not, and they said, oh no, we are not worried about mycosis fungoides, but we are really mad against our dermatologists who told that this is vitiligo. You have nothing to do, you will have your vitiligo all your life, you can go out, and it was 5 minutes. And when they go out, 2 days after, the young boy tried to suicide. So be careful when you see a patient what you are saying to him. It's really important. At the first consultation also, we try to do a tree to see what is associated, and we look carefully for thyroid diseases. In children, it is less common, but you should screen thyroid disease in all patients with non-segmental vitiligo, not segmental vitiligo. Segmental vitiligo, we don't care, but not segmental vitiligo, you should screen them. And you have almost 30% of patients with vitiligo who will develop once in their life thyroid disease. And you should also carefully look at the size of your lesions, because the cardinal phenomenon is very important in vitiligo. I always say that, and you will see some pictures that we show to our patient in our clinic. When you have this, you see that your vitiligo is really, really, really active. You have this kind of cardinal phenomenon. Anything when you scratch, you will have whiteness coming. And you see at the border, you have this tiny depigmentation, very, very small sized lesions of vitiligo. This is really something witnessing the evolution of vitiligo. And this phase here, you should use steroids. It is important to see those signs. Again, see all these pictures. We use these pictures in our clinic routinely when we see a patient. It is important to tell him that they should avoid all the things that can aggravate vitiligo. So this is true probably more during, and it is part of the treatment to say to the patient, you should not rub, you should not do this, you should not do this. We usually give them a form, and they go out with the form. They say, I will never do it. And the next time when they come back, they say, well, we are trying to do it, and it's becoming easier now. But in my experience, this is true during the flare-up of vitiligo. Once the flare-up has gone, usually cardinal phenomenon is less present. So what about the treatment? In children, there is a lack of controlled randomized studies in the pediatric population, and this is a shame because we need controlled randomized study in order to have evidence-based medicine treatment. And only 7 studies, we just have completed the Cochrane review where we screened almost 100 studies, and only 7 studies were specifically dedicated to children. More generally, the treatment of vitiligo will include 3 types of treatments: topical therapies, phototherapy, oral steroids, and usually we use combination therapies, and I will tell you how we use them. Cosmetic camouflage is also part of the treatment of vitiligo, especially for very fair-skinned patients.